I'd like to introduce our host, Dr. Lawrence. Dr. Lawrence received his MD degree from the University of Texas at Houston Medical School. Since then, Dr. Lawrence has been on a crusade to bring the safest and most effective technologies to his patients. He feels it is his responsibility and privilege to share these techniques with medical colleagues. Dr. Lawrence's focus is on cosmetic surgery with specific interest in laser medicine, sclerotherapy, and cosmetic surgical procedures. Dr. Lawrence is certified by the American Board of Laser Surgery. He is also a member of the American Academy of Cosmetic Surgery and is an associate clinical professor at the University of Tennessee in Memphis. And with that said, Dr. Lawrence, I'm passing the ball to you, and it's your presentation.
Very good. So I assume since they have the option of pushing a tab up at the top left to see my video, they also have the option to not push that tab and just hear my droning voice. Is that correct?
That's correct. If they don't want to watch, they don't have to.
That sounds great. Well, listen, I'm going to go ahead and grab my pointer up here and make sure it's functional. There's a little red spot on my rather obvious glowing head right there. Listen, it's a pleasure to get to talk to you guys. Anybody that knows me knows that I'm passionate about aesthetic medicine. I love to speak with colleagues, and tonight I've got the pleasure to speak with what has really been a very, very good experience with a laser, and many of you who have lasers will be able to say quite honestly to your spouse or to your colleagues that every laser that you have bought has not been a pleasure. Every laser has not made you friends among your patients, and every laser that you purchased has not technology is that it wasn't my first fractional CO2 laser, and my first laser I had a good experience with, but I knew that I should be able to do more, and with the next two I was able to do more. So I'm going to try to move through this presentation, and let's see, I'm hitting an arrow and it's not working, so let's take my pointer off and see. Because if my moderator could let me know, do I have to take my pointer off to advance? Because I'm not advancing with my arrow.
You can click within the slide and then press the space key. That will advance the slide.
It did. Very good. So as everybody on this call is probably aware, fractional CO2 has taken the laser industry by storm. Any of us who've messed around with ablative lasers and tried to give rejuvenation results with non-ablative lasers have been disappointed. We've done pretty good with some dyschromia. We've done really well with telangiectasias, but otherwise, really rejuvenating the skin we have not been able to do. Anyone on this call who's older than 50 probably has some experience with traditional CO2 resurfacing, and you know that that, along with other ablative technologies, that is dermabrasion and deep chemical peels, so that there's some pretty significant risk with those, even though they've really been able to rejuvenate the skin well. So I'm not going to make any assumptions during this call. I'm going to try to take a view of 20,000 feet and cover things generally, but I'll also try to get into some details, so no matter what your level is, we'll take something away from this call and say that it was worth your time. So what I'm noticing on this screen is a really, really important thing, is that I love the 180 spot size. I don't use the 300 that much. A lot of physicians do, but my practice is focusing a little bit more on more aggressive results. I'm going to talk to you about how pleased I am that we've been able to get results of an improvement in patient skin by a measure of 5 years, 10 years, 20 years, especially in combination with volume and other minimally invasive techniques. And I don't see being able to get that good of a result with the 300 micron. But the 300 micron is really fast, and it is appropriate for the face. but I don't do a lot of off-base work. For those of you who are beginners, I wouldn't expect you to really use fractional CO2 technology off-base at the beginning. I do have some colleagues that have reassured me that they've done some amazing things off the base with fractional CO2, and I'm a very cautious person, um, and I just feel very at ease being aggressive with the face. I don't feel really comfortable being aggressive off the face, and I believe that over the next year I will start doing a lot more off the face, because as I've interfaced with colleagues, I've really found that they're getting a lot of good results. I'll give you an example. I do a lot of abdominal work, and sometimes you see tucking into some skin on the abdomen, we get a little bit of a dog ear. I've had a very reliable, credible colleague tell me that they've hit that with the fractional CO2 technology and have every single time been able to lay that dog ear down. I'm really impressed with that. So anyway, I use the 180 spot size, and we'll get to that in a second. I'll make that real for you. And I do want to also take a step away from this and say, don't hesitate to instant message me with the chat screen, and it'll make certain that if I skip something or I misstate something, you guys can give me some hints about what I need to do. When I'm off the face, I just really feel like the 180, just the smaller beam size, the 180 micron beam size, allows me to deliver more energy to the tissue. So for me, the 300 would allow me to be fast and fairly aggressive on the face, but not get quite so deep. And so I'm going to be a little bit limited in how many years of improvement I can get them, but I can really do a lot with that 300. And it may just be my inexperience and not really being able to tell you how to work off of the face. I think at the end of the day, you're not going to be able to charge in terms of a fee anything for off the face like you can on the face. So I think as a practical consideration, talking about on face is really something that we ought to be doing right now. So we have this term, ablation, that everybody's familiar with that is. That is basically either evaporating or coagulating tissue. As you know, when I talk to my patients, I describe ablation as being any type of ablative technology out there where there's mechanical, for the tissue to look like, raw meat. That's ablative therapy. We know it's the most reliable in being able to give somebody a really, really good result. So when I use fractional CO2 technology, I like to refer to it as semi-ablative, because we are leaving some of the dermis and indeed the epidermis intact, but we're drilling down really deeply in a fractional way. We can get to depths that you never would have dreamed to have gotten with full resurfacing, because you're leaving these tissues at depth that allows you to actually be more aggressive. And you'll see by the results that I've had and a lot of other of my colleagues that the results are really, really phenomenal. So yes, we do get tissue contraction. To me, it's the most difficult thing to achieve. Fractional CO2 really opened up a new universe for us compared to what we were dealing with a mixture of non-ablative lasers and radio frequency and ultrasound technology. In my opinion, the tissue contraction is still the most difficult thing to do, and I'm pretty sure that in the years to come, I'm going to be combining my mix-tube and other heating, whether it's radio frequency or ultrasound technologies, to get more contraction. But for me right now, fractional CO2 is the most reliable tissue contracture that I can get, especially on areas that are not as heavy. The jowl area is extremely difficult, even with an aggressive fractional CO2 technology, to get contracture, but it's the best of anything that we use. It is the most reliable. It does great on other areas of the face. Again, we're fixing to see a little bit of a cartoon of this, but you're going to have a zone of vaporization where the laser beam hits the skin, a zone right outside of that of necrosis and cauterization. This presentation makes a differentiation between a higher wattage with a short duration that vaporizes versus a lower wattage and a longer pulse width that causes more of a coagulation zone. To me, these are rather academic. They are real, but they're academic, and I'll share with you a little bit about how I approach the face as far as energy levels go a little bit later. But suffice it to say that we're looking for everything. We love vaporization. We love coagulation. The necrosis is not bad, and we do get tissue contraction when we do aggressive treatments. Again, you can see the energy is absorbed. Once you reach a certain amount, the tissue is actually vaporized. There's always a zone of coagulation right outside of that. That zone of coagulation is critical because of how it works. And we really don't understand it. So this is kind of looking through a cut through like a donut. You're looking at a zone of vaporization and a zone of coagulation. Yeah, just a little. You really can't use fractional CO2 without being able to talk to patients during a consult about what the technology is and how it's different from traditional technology. So some of you guys are very knowledgeable about CO2 lasers that came on. They were wonderful. You could cut with them. You could resurface with them. I'll show you the schematic in a minute that kind of shows what a non-fractional treatment looked like. The old CO2 lasers had a scanner just like the ones we have now, except when they scan, they hit all the tissue with basically these overlapping donuts. So this is kind of important from the standpoint of you as a clinician kind of understanding what's happening with the energy. When we went from super pulse to ultra pulse, what we were able to do is basically allow energy to go into the tissue in a pulse way. And what that did from a standpoint of cutting is it caused there to be less peripheral damage to the tissue. So whatever tissue you vaporize. There's a very, very thin level of coagulant. And I've got a train going by. I'm in a very picturesque environment in Germantown, right outside of Memphis, Tennessee. And I guess the physician that first built his building in 1886, where we locate our medical practice, built it right next to the train station. And so it's a wonderful medical office for us, but we have to put up with the train every once in a while coming by. So if y'all can message me if that train gets so loud that you can't hear anything. Anyway, so back to the ultra pulse and the super pulse. So the difference historically between going from a super pulse, which was, I don't understand all the electronic technology behind the beam of the generation of the beam, but used to the technology didn't allow us to turn off and on immediately like ultra pulse did. And so the ultra pulse was an advantage in that it allowed for cutting technologies for us to be able to have as minimal of a zone of coagulation as possible from using it to cut, like you're doing a blepharoplasty. And you could do that with your niche too. You could get a cutting handpiece with it, and it's really, really wonderful. But what I want to tell you is that the value of, and I'm not going to really name any other brands out there, but the value of having a continuous way of energy for doing fractional resurfacing of the face is really great from a marketing standpoint. I'm going to show you some of my photos in a few minutes of a patient 1 day post-treatment, 4 days, 5 days, 7 days, 9 days. And what you'll appreciate is although they look a little bit worked over, they don't have that look that patients had that were treated with ultra pulse or super pulse resurfacing technology. Those technologies have no coagulation, and because of that, they really have blood running down their face, and they just really they don't present very well to their family members or to themselves, and it just is, from a marketing standpoint, it's really difficult. I don't think you really get any advantage. You get a little bit of extra depth with that, but I'll reassure you that I have no trouble with continuous wave technology being able to get to the depth that I want to get. Here's a good cut through of skin, kind of let you know the depth. These are not to scale, but you can see using some different energy technologies Irving had, and using CO2, what kind of different depths you can get. I guess the main point is, I'm not sure how well this demonstrates it, but SuperPulse technology can go a little bit deeper. There's less of a zone of coagulation, and these patients bleed because these capillaries that you get. It's all good. Again, here's it's really fun to kind of start playing with your laser and doing some different things. I'll give you some starting tips, and just within several weeks of having your laser, you can be doing pretty amazing work. Again, this kind of points out some differences between UltraPulse, SuperPulse, and continuous wave technology, and how well they do relative to thermal damage, ablation, and skin tightening. I agree with this. I think continuous wave is better. This just points out why you want the heat, because it causes contracture, it causes a coagulum, that serves as sort of a temporary bandage while new tissue grows in. It's really nice to have a dry surgical field that you're working with when you're doing resurfacing. Decreased risk of infection, maybe, but it's the only way I would do it. So there's several references out there that agree that this is a better way to apply energy to the face. In my experience, we get results that nobody else in our geographic region has ever even gotten close to. And we've been performing fractional CO2 therapy for about 3 years, and we've been using mixed technology for close to 2 years. And as I'm talking about here, I am going to glance down and see if anybody's asking any questions. There's a question about patients who are internet experts. Wow, I embrace the internet. At the end of the day, patients do come in with ignorance, but I think they come in with less ignorance after they've read the internet. It's so great for them to come in with a working vocabulary, and those consults for me are actually a lot faster, even if I have to reteach our patient what the truth is. And basically, you can tell the truth with photos, and we're able to go through photos and do a consultation and have patients really quickly knowing that they don't want to go anywhere else for their technology, for their treatment. And I think we charge a lot more than anybody else does for fractional CO2 treatments on the face, because we deliver a result that's a whole lot better. So here's a great visual. Traditional resurfacing CO2 actually overlaps. The laser beams overlap. You can see with fractional technology they don't, and you get this skip around, which causes heat not to build up too much in any one area, dissipate, and when the beam comes back around to the neighborhood, you're not stacking heat on top of heat. So it allows you to be more exact in your treatment. Listen, you can do another pass, you can turn the watts up to 30 watts, you can deliver as much energy as you want to, but when the scanner skips around, it allows you to do a more smooth, even treatment, and it makes it more predictable.
Dr. Lawrence, let me pull up the video real quick, and we can play this.
And while you're bringing that up, I'm going to just make a mention to the fact that I do not like to treat skin type 5 and 6, or I'm very tempted because those patients with melasma and other dyschromias can respond really well to fractional CO2. But the 1s and 2s and 3s, you're just not going to have any problems with them. The 4s, if I want to do a treatment on them on a scar, or usually they don't need the extent of rejuvenation because they're beautiful, protective skin that doesn't have nearly as much photo aging. So it's a different type of thing that they come in for. And so as a general rule for my skin type 4s, I might even feel a little bit comfortable with some of the peels that are out there. But if they insist, I'll do a skin test on them. And I've had a lot of skin type 4s that have done very, very well with fractional CO2 technology. I would urge you to talk to some other docs that have some more experience with skin type 5 and 6. I'm sure there's some success out there with using some a 5% pattern and things like that. Certainly, our patients with ethnic skin deserve all that we can give them in the way of laser technology, and I think they may be a candidate for mixed too. And I have a huge African American population base, but I see most of those patients for doing tummy work and breast work, and I don't do as much face. I don't have as many face patients that present from the African American or Hispanic community. I can't see the video. Can anybody message him if you can actually see the video? I can't see it. And I can't hear anybody's voice.
Yeah, the video. This is Bob. The video is playing right now. We'll go along with the presentation if it's not being projected, so you can continue if you want.
Okay, sounds great. So you guys may or may not have seen the video. You can look on YouTube under Mixed to it. I'm sure you can see plenty of those scanners out there and exactly what they look like. It's pretty cool. Let's see. I am now. Go back to this presentation. And I'm successful here. So you can see the difference in the 300 spot. If you were to see the scanner in motion, the 300 is a lot faster. This is that I probably should be mixing my passes with the 180 and 300. I think that would allow me to do the superficial work a lot faster. We don't currently do that a whole lot, but as I give a presentation like this, it makes me think through what we do on a daily basis. We do a lot of mixed to fractional CO2 laser treatments. We actually have, I think, 10 or 11 lasers or energy devices in the house, including radio frequency, light, every wavelength, T-switch laser. And so we do, our favorite laser in the entire building is the fractional CO2. And none of our other lasers generate income nearly as well as our fractional CO2 mixed does. So you could and normally when we're doing a face, we're doing several passes of the 180, and I'll get my pointer back up here again so I can look really cool and point like you would know when I point at. So here's the 180, and it's deeper. And let's see, this doesn't say exactly what energy was used to do this, but I'll tell you a little bit about the energies that we use. They're quite high. I've only had one patient ever that had what she called the scar. Maybe I've had two, and maybe had one that I would basically. We've probably had in over 150 aggressive full-face fractional CO2 treatments, less than a handful of patients that had any effect on the natural pigmentation, and only one patient that had a little area that she considered to be a scar, but her result was so phenomenal that there was no complaint with that patient, that she had a little area that every time she put her makeup on, she kind of felt like it was a little bit of a scar. Really an excellent result. So anyway, that's what our experience is. And I guess when I turn my there we go, perfect. Again, looking at the difference between the 300 and the 180 spots, I'm going to go on from here to the zones of coagulation. This is a really helpful slide. As you can see with the 300, you've got a lot bigger footprint, and it lays down a lot faster. So you can imagine if your footprint is smaller like this, which is the one that we usually use, it takes quite a bit longer. And there's a lot of different ways to do this. Anesthesia is obviously very, very important. For my patients, we save them the cost of general anesthesia. We use blocks. Topical is not appropriate, but blocks are. The Zimmer is. Senescence is. IV sedation is. You can do that. You don't have to do that. A lot of my colleagues do full-face treatment with the mixed without anything but a little bit of oral medication. So as an anxiolytic, and these treatments go very well. But this is a good little, this is just to let you know, this is the one I'm pointing out right here is what we use as our workhorse for going across the forehead, cheeks, all the way down to the neck, into the neck. And we use this footprint right here, or maybe this, when we're doing the upper eyelids. There's something that allows you to do a few zones of energy going down the upper eyelids. And we've had amazing results with basically a laser blepharoplasty without excisions, which I hate that because I love doing excisional blepharoplasty, but patients sometimes don't want the excision. Again, a really good example looking at density. You can see going from 5% down to 40, and you can kind of see what that densities look like. And we use a lot of 40. We don't use 5 at all. We use a lot of 10, and we use 20. Again, I'll go over my tips a little bit later. Again, like with any laser, you not only are dealing with fluence, you're dealing with what your dwell time is, or what your pulse width is. And you can just see this is just saying as you increase your power, you're going to go deeper. As you increase your pulse width, you're going to increase that zone of coagulation. Of course, you also notice that as you increase the power, even if you don't increase the pulse width, you're going to increase your zone of coagulation and necrosis. And here's just this is a real impressive part of the presentation because you're going to look at these photos and know that these are the real deal. How many lasers have you seen where the before and after pictures were taken at different lights? And it's just kind of really, really iffy whether you're getting a result. We've had some unbelievable scar results. This kind of right eye correction isn't unusual. This isn't like, well, we treated 100 patients and we were able to pull out 3 sets of photos. This is a really, really good representation of what we expect day in and day out on our results. So the issues are everything from pigmentation improvements to even severe right eyes. Scars do better with fractional CO2 technology on the face than anything else available. You do well to combine that treatment with fillers or with some scar subcision, but it's amazing what kind of results you can get. I'm gonna break and take a sip of water and look at the last IM that I had that came in. And someone asked what my conversion rate fractional CO2. Well, the name of the game isn't fractional CO2. I don't sell fractional CO2. I sell a better face. And I talk to patients about what it is that's going to make them happy. I tell them, I use the illustration that I don't like to deal with singles and doubles. If a technology isn't going to deliver to me a triple or a home run, I don't really want to mess with it. I can accept the single if the patient can accept that result, and maybe they're so risk intolerant that they won't let me give them even the most very small risk, and so I have to maybe go with a very non-aggressive treatment, or maybe they just don't want any downtime to speak of. So, but at the end of the day, I don't sell fractional CO2. I don't sell mixed two. What I sell is an improvement in the face. If that means, liposuction in the neck, that's what I'm going to do. If it's telling the patient no for what their budget is, it sounds like, the best you can have is an upper eyelid blepharoplasty. That's what I'm going to do. Now, it turns out that this is a sweet spot for facial aesthetics. Patients very, very, at a high rate, will accept the cost, the downtime, and the results with a fractional CO2 resurfacing. We're oftentimes combined it with liposuction of the neck we're oftentimes combining it with minimal incision work on the face, whether it's a blepharoplasty or a small incision facelift or an anguloplasty to improve the smile, something incisional like that. We're always combining it with facial fillers, and we like to use the fillers that have the highest margins. So we probably use Juvederm on every single patient that we do a fractional CO2 on. We probably have our best margins on Artefill by far, and so we like to volumize the face because you really can't get a result. I'm pointing at this particular patient right here. You can't get this type of result with laser alone. It's not labeled, but clearly this patient had a little bit of volume in her cheeks as well. And guess what? It's a perfect time to do it while you're doing your laser resurfacing because the patient is numb, they're under their block, they're comfortable, and so we like to sell them a result. So that's usually a package, a fractional CO2 resurfacing along with their volume that they absolutely have to have. Very, very infrequently will patients just tell us to do the laser and come back and do volume later. We'll find, even if we have to give them the volume, we'll let them pay their, $5,000 or $6,000 for their fractional CO2 treatment, and it's our reputation. So if we had to give them some of the volume, we give it to them. I think that's just what you have to do to take care of patients. Okay, so let's see. There we go. Perfect. Okay, so this is me, my treatment plan, Dr. Lawrence. And by the way, my email address, if you want to write it down, just in case you have a private question that you can't or don't want to, you kind of want to say, what's the real scoop on this? Do you really, were those mixed scoop guys paying you off? And the answer is no, they're not. I really love doing this. And so this is just something that I like to do, and I'm really looking forward to doing another one of these down the road. But if you have a question for me, my email address is superdoc, like Superman, but superdoc, D-O-C-G, superdoc-G at gmail.com. If anybody didn't get that, just IM me, and I'll tell you what it is again. So here's what I do commonly. This is the way we approach, and I'll show you some of our photos and show you the results that we're usually trying to get. We don't really like to do treatments that are minimal. We like to, talk the patient into doing something that's going to really address all of their issues. Sometimes we'll do a partial face treatment, like a perioral or a periorbital treatment. I'll show you one of those in a minute. One of my staff had one of those yesterday. But we usually are doing full face treatments, and we're doing 3 passes. Watch is the highest that most fractional CO2 laser boxes will go. Mixed 2 is no exception to that. There's some reasons why I like Mixed 2 better than my previous fractional CO2 laser. I've already talked about the continuous wave versus the ultra pulse for the super pulse. I also can tell you that it allows you to make every single change that you need to make to do whatever you want to do. I don't really understand how I could, in 10 years, I could still be using this laser and be doing really, really well with it. I'll probably be combining it with other energy technologies at that time, but I don't think we can get any better at what this technology is delivering by itself. There's not going to be a single technology that can overtake what we can do with this. So think of it this way: 30 is the highest, and when you have it on the highest energy, the highest fluence, you need to be cautious about how much coverage you're doing. So we talked about it going from all the way from 5 to 40%. So if you're using 30 watts, you could use 15 if you wanted to, or usually combine it with other passes. So we use it at 10% by rule. We do exceptions, but usually when we have it on 30 watts, we're at 10%. We leave, again by rule, the pulse width at 2,500 microseconds, which is 2.5 milliseconds, which is, in that technology, it's an 8i. I guess some egghead physicists decided to put that in there that way. But we use an 8i, an 8 index for our pulse width for almost everything we do. Sometimes we're trying to get a little bit deeper, and we'll change it to a 7i, which is 3,500 instead of 2,500, and for pulse width, and to get a little bit deeper. But generally, we kind of like to stick with the same energy. A 20 watt, 20% is our workhorse. We don't just put a whole bunch of passes at 2020 because we usually try to be a little bit thoughtful about how we're covering the face. When we're using a 10 watt, we're pretty tight. Usually we're going 40% when we're doing 10 watts. That's more of a resurfacing thing. Now, the only place on the face, and that's what this is down here, by the way, standard 8, that should be a lowercase I for index duration. That's what I use standardly. What I was going to say is the only area I want you to be somewhat cautious about is under the eye. Under the eye, the tissue contraction that you get is so good and so effective that you can actually cause an extropion. I've never seen one stay, but as I'm doing the treatment, you can see that skin tighten up as you go. Pretty impressive. And so I'm always real thoughtful. I do a snap test. I look at that area, and as long as the tissue, as long as they don't already have a lower eyelid that pulls away, but they're a little bit of an extropion already, or if they have a lot of scleral show, I'm going to be a little bit more cautious. But otherwise, this is an interesting side note. We all know that the skin on certain areas of the face, like perioral, is several orders of magnitude thicker than other areas. For instance, the thinnest area on the face, which would be periorbital. But at the end of the day, for some reason, you can still use incredibly high energy on these areas where the skin is thin. I'm only cautious in the really old patients that have paper-thin skin. I'm going to be more cautious in those. But just about everybody else, you can really be aggressive everywhere on the face, including we use some wildly aggressive settings on the upper eyelids to be able to cause redundant skin to contract. And we haven't even had a patient with delayed healings. They're very predictable on how they heal. So that should give you a lot of excitement. I want always be cautious. Start a little bit with less energies until you get comfortable. But we use pretty significant energies here. And Alan from lasering will probably let you know that when you get your laser, generally you can come out and do training with a physician who's as experienced as me, if not more. We also, of course, are open to doing some advanced training with patients. And so this is all things that you can get going on. This is just pointing out that they've got one of my photos listed here where Hicks2 just cleaned up over the last couple of years at the aesthetic show. Really, really neat, really kind of compliments to them for their non-surgical win that they have this year with my photos and last year with another physician's photos. So this was the one that I had entered. So this patient does have volume. I did initially do a peel on her, but then I used fractional CO2 to really give her final results. Nowadays, I wouldn't even think about doing the peel before I did the fractional CO2. This patient's, in fact, I would rather use fractional CO2 technology because we do what we call a pre-pass, which before we do our pre-passes when we're doing aggressive resurfacing, I'll go over in a real specific kind of artistic way so it doesn't ever show up as a line, but we'll go over these smoker's lines, these vertical lip lines, and we'll also go to other areas on the face that need a little bit of extra, and we'll go ahead and hit those before we do the pre-passes. So I could have really been a little braggadocious. We have so many sets of photos that just show great, great results. Instead, I'd rather show you other doctors' photos too, so I can tell you in my hands, this is the result that we get day in and day out. Now, my individual approach to forehead lines, remember, most people don't want to have live their life on Botox. And so, especially men, so you're looking at a man right now, and you can see how this is at 2 weeks, either 2 or 3 weeks, you can see how where I treated his his horizontal lines with some pre-passes. Kind of see where it looks a little bit extra red right there. Well, we've resurfaced the entire forehead, and we resurfaced his glabellar area. We did extra passes on the glabellar creases, on the horizontal creases. We put a little bit of long-term filler. In this case, this was Artefill that we put into these lines to really kind of help the laser. You really want several different technologies to help you. I'll even take a patient like this and pre-treat them with Botox and tell them there's a good chance they won't have to have repeat Botox, just so that while they're going through the healing process, those muscles aren't working on the skin that's building new collagen, on the filler that you want to stay in the space that you've injected it. And we have had results with mixed tube laser aggressively treated on the forehead that, in my opinion, beats a surgical brow lift. Long-term surgical brow lifts can do good, but really a high percentage of the time, I have very dissatisfied patients who come to me from other surgeons who had a brow lift. And I believe in a brow lift, but I think if you try these other things first, you'd be amazed how many times these patients don't have to have an endoscopic or an open brow lift. Again, I want you to know that this isn't one result out of a million. This is the type of stuff that when I see a patient like this, I kind of expect them to get this kind of, and it doesn't say right here, but I'm assuming this was not an upper eyelid blepharoplasty as well. And I think you can appreciate how amazing that tissue contracture was of that upper eyelid to go from here to here without any surgery at all. Again, we'll get these results day in and day out every time we use the technology. It's pretty remarkable. And what I really want to point out looking at this photo is in the olden days, we could have used dermabrasion, we could have used a deep chemical peel, or we could have used full resurfacing CO2. And at the end of the day, we always could have gotten a result like this. The problem was it took longer to heal. There was more of a risk of scarring, and these patients were almost guaranteed to lose their natural pigmentation. This is a patient that has rather olive-y skin. You can see that she's maintained a lot of it. I can tip my patients that they could lose some of their natural pigmentation, but with aggressive fractional CO2 technology, they rarely do. I'm going to go ahead and look over at what I've been IM'd here. There was a question about what settings are used for a pre-pass. I'll kind of explain a little bit. If I was treating this patient, and let's just visualize that she's also got some severe telangiectasias on the nose. I think I can kind of see some of them there, but let's just assume that she has that. Our point of the pre-pass is going to be, we're going to use the smallest footprint that we can with the mixed tube. We're going to use one pass at 40% 10 watts, one pass at 30 watts 10%, and we're just going to, in a very, very out of register way, we're going to do those two passes right there without any overlap at all of the identical energy. The two different energies can overlap, but don't overlap your 10%, don't overlap your 40%. And make it like a little bit of a meandering snake along that line. And hit maybe her three major lines with that pre-pass. Hit maybe some lines going across here, her most severe lines. And then we actually will, part of our pre-pass, will hit those telangiectasias with a surgical handpiece. I'm not going to share with you those settings because that's outside of the scope of this talk. But I have gotten where I love using the surgical handpiece to ablate those. As you know, if you have a pulse dye laser like I do, or a YAG laser that has a real small spot size, you can do a pretty good job with these. But it's still kind of hit and miss. And a lot of times, do the second or third treatment, especially these ones on the nose. the fractional CO2, the mixed-2 laser with the surgical handpiece, using the appropriate settings, does a great job of getting rid of these type of things. I've even started to experiment on using those veins on the temple, and have had good success using a different set of energy settings for those. So again, if I was pre-passing this gal, I would hit her major 3 lines going across here, and then I would probably do, instead of 3 passes, I'd probably do about 4 passes around her mouth. Remember, the skin around that mouth is very, very thick, and it can tolerate a whole lot of energy. Again, wow, that's just remarkable that that we can get results with one treatment. Now, it doesn't say that this patient has some filler in here, but really give yourself a break and give yourself some help. If you're going to do Mix2 or any other laser trying to kind of help with these vertical lip lines and these smoker's lines, also go ahead and volumize the lips and chase these lines with your filler. That way, you don't have to ask the laser to do all the work, and you don't have to push it to its limit. And really, using any other laser in our building would be unconscionable. Really, the Mix2 fractional CO2 is the only way to take care of this type of an issue. We used to use other lasers, but not anymore. Wow. This demonstrates what I commonly see, an incredible improvement in pore size. Of course, you can see her dyschromia is also amazingly improved. She did get a lot of volume. I would love to volumize this now. She could, and after you go to Mix2 treatment on her, you're going to own this woman for the rest of her life. This is 9 months post-op. At that visit, it wasn't 3 months. I'd be talking she's going to volumize, and what her best options are for volumization. And you may collect more in revenue from getting her in the right state as far as volume goes than you did from your initial Mix2 treatment. These patients need volume. Very, very typical. These are the results we see day in and day out. I could probably predict which one of these patients have a little bit of volume. I think she might have a little bit of volume, but just Mix2 by itself do a great job on this gal in her under eye area. I'll actually use some settings to get deep enough to hit that periorbital fat. Volume plus fractional CO2. Great result. Good stuff. Beautiful skin. I mean, that's just amazing that you can go. This poor person doesn't look horrible. She just doesn't have pretty skin. And her skin here is just incredibly gorgeous. Look at the tightening on that upper eyelid right here. Again, we see that day in and day out. Acne is else. I don't kiss them back. Okay, I'm looking over at my another scar patient. I'm looking over at IM. Sorry if I missed a couple of questions here. Okay, great. I'm going to show you my esthetician here in a second. I think I'm close to the end of these photos, and kind of let you know what the healing progression, because there's not really any photos in here that show the progression. And I think it's good to kind of see how wonderful that progression is. Another great result. I wish I was the only one in the country having outstanding results with my Mix2, but obviously from the slide presentation, and you see in the credits here, gorgeous. This kind of permanent loss of pigmentation. As soon as you get rid of the dyschromia, they have gorgeous skin again. They could go to the typical skin specialist in town and wouldn't be offered anything except some topical products that would be almost impossible to get that much improvement. Beware of type 4 skin, but it certainly is treatable. Just take a good history. Consider doing a test spot on an inconspicuous area. Oh, definitely, that's going to be a growing area for us. We wear out our Mix2, but we'll be doing more areas. Yes, treating these scars. I have a lot of colleagues who have a lot of success treating surgical scars. I'm going to try to do this. Let me look at my questions. When I do multiple passes, do I decrease the energy or density with subsequent passes? You know, at the end of the day, they're fairly similar in their density, because as I increase the watts, I decrease the density. And so I'm using a 40% 10 watt, I'm using a 30 watt 10%, and so at the end of the day, those are fairly equivalent to a 20 watt 20%. The difference in those three passes, and one of them is very superficial. You could probably use your 300 scanner instead of your 180 scanner, and you would end up you could do that superficial treatment a lot faster. But at the end of the day, that's just the way we do it. That's kind of that's the way we roll. So anyway, so let me do this. This allows me to show you my desktop. So it's supposed to be really quick and really easy to make sure I do this right. I think it is under share, my desktop, yes. So what I'll do is my desktop is showing to me. I hope it's showing to you all right now. These are not, sorry, these are not any particular order. I can tell you about how many days they are. And I can go to full screen if y'all can still see it. And I think my host is going to be able to work the key, and therefore you guys as well see this whole thing screen when I push this button right here. Everybody seeing that?
Yeah, sure, they're coming up fine.
Okay, good. So let me. So this is just scrolling automatically through. This is one day post treatment right there. This is about 5 to 6 days. I mean, this is my esthetician came back to work. 8 to 9 days. She could be wearing makeup over that. This was her baseline. You could. I'm gonna let that shine. I hope to see it in high definition, so like I've got it first today. And there's going to be one more picture of her face. Oh gosh, I don't think I'm going to take time to find it. But again, this is my esthetician. Look around the edges of her face. It's very, very. You do your treatments, and this is one of the reasons I like doing 3 passes. It allows me to put your scan base. If you're not careful, if you're doing an aggressive treatment and you're standing, those little wide angles, it's very annoying to patients. And so what you want to do is make sure you not only lay it down in a different registry, subsequent passes, but around the edges, you want to feather the results. There's a couple different ways to feather. Whenever you get your, you can be shown how to do that. But at the end of the day, you feather it into the hairline, you feather it down into the neck, you feather it onto the ear, and even though this patient, again, was my esthetician, was 3 days before this photo right here, was already going to Kroger. This is her baseline again. You can see we also gave her volume under her eyes and her cheeks. I think we did 2 artificial tips on her. This is my, again, esthetician. My nurse is at 1 day post. She had saggy, baggy eyes. And what we did was we volumized her, and we did a treatment under her eyes only. But you can see how we feathered under her eyes. So even 1 day post, she doesn't look this good. It really in about 4 or 5 days. Again, this is the esthetician. I'm waiting for it to go back to the nurse. There's my nurse right there. That's pretty amazing, that healing. I wish you could see her face. We literally took 15 to 20 with her full face treatment, and then I was dissatisfied with her under eye area. I'm not talking about my esthetician here, I'm talking about the nurse. Staff actually did a follow-up treatment on it just around her eyes, and all I did was improve the settings, and the staff did the treatment. I'm in treatments intimately, but I have such a good staff. Treatment team lets me go eat lunch while they're doing some of the passes, and they top. So it always speaks highly when your staff wants have a particular technology that they see patients come in. Charlotte, who you're looking at right now, so she has a little bit, so we were careful under her eyes, but I do her under eye area. I'm not going to treat it really, really aggressively. She's got dark circles under her eyes right there. Need laser as much as she needs volume, so we placed that. So we, of course, laser her, of course, for bow to stern. It's really, really neat how when you tether onto their neck, and you can not look surgical. They can literally put on mineral makeup predictably at day 6 to 8 in normal activities, and even without makeup, sometimes all they do is look like they just got back from the beach and should have worn some sunblock on their face. So anyway, I'm going to go ahead and shift back my presentation, and we're going to go in time where y'all, I don't know if y'all are going to actually be able to come on verbally. I think you're going to request digitally, and I'm sharing my desktop right now, so I'm going to look right over to my instant message area, and I would love for this to be a little bit more didactic and for me being able to actually talk to you guys, but at the end of the day, these presentations are put together this way so that you'd be relatively assured that it's going to be a 1-hour presentation and the speaker is going to get off track. And so I hope I have it. I hope I was able to give you some good examples about how the Mix2 laser has really, I would say, with everything that we've added to our practice, we're a facial, full body cosmetic surgery practice. We also do EPLA, we do a bit of a vein practice as well. But out of everything that we do, probably, without a doubt, the most exciting technology that we ever embraced was the improvement that we had from our previous fractional CO2 box to our Mix2. So anyway, I'm willing to answer any questions that anybody has. I'm going to shut up for a second and see what comes up.
Yeah, and Dr. Lawrence, just some came in to the host that you might not be seen, but can you explain your injected anesthesia in more detail? Basic blocks aren't covering everything.
Sure. Yeah, along the periphery of the face, you're always going to be really spotty. And so all the callers on this call are familiar with blocking the 3 branches of the fifth nerve, and you know how to do that. We always block those fairly aggressively. I mean, I know that really, really good blockers can use a half a cc to a 1 cc and really get a great block on region of the face. I'm not as good, so I start with some lidocaine without epinephrine just to make sure they don't feel quite as much of a burn. There's a little bit of ice first, actually a little bit of topical anesthesia before that. So here's how it goes. Topical anesthesia, ice, 30-gauge needle with plain lidocaine to just numb up the skin. And I might even put it a little bit deeper. Then my workhorse is my lidocaine with epinephrine that I inject right down on the periosteum where the nerve is penetrating through. And if I don't get a good block from there, what I usually do is some double strength clients. That would be a 0.01 lidocaine with 1 to 200,000 or so epi, and we'll actually do a little bit of a regional or senescent type of block. Anywhere where the patients feel anything, we'll go in, and if we have to put in, you're not going to run into any safety issues with using as much volume as you need to. If you limit your first block to about 10 to 15 cc's of 1%, and then use as much double strength lines as you want to around the hairline where sometimes they're sensitive or otherwise in the periphery. And, just be patient. I've seen a lot of my colleagues do this without a single assistant. They just do the laser, patient feels something, they put the anesthesia in, wait a couple minutes, and go. I don't know what your time is worth, but this is a very high dollar procedure. And if you have to sit there with the patient for 3 hours lasering because it's what you love to do and making sure they're anesthetized, there's all kinds of other things that you can do to help patients relax, whether it's an oral cocktail, whether it's nitrous, which all of our dentist colleagues have learned to use very well. There's a lot that you can do to kind of get patients comfortable. The main problem with nitrous is that a lot of times whatever delivery apparatus you're using will be in your way for most of the procedure. So one tip on this is I'll tend to go down into the neck area with anywhere between 20 to 40 cc's of that double strength line early on in the procedure, because the neck doesn't tend to block nearly as well as that local anesthetic down into the skin early on in the procedure. That numbness will remain for hours. So most of our patients leave their treatments in zero pain because of the block that we use and the senescence that we use. And really, at the end of the day, the picture that I showed you of my esthetician, she had literally zero pain during the entire post-operative course. It's quite amazing. Some patients will have some burning, especially when they apply their topical or where they wash their face. But really, the discomfort doesn't at all is anything like what the patient looks like. Very minimal. What else?
I'm sorry, Dr. Lawrence, did you see the question in the Q&A box? There's some interest in you discussing more about acne scarring, the scarring treatments, and do you do any cutting of the scar edges?
Yeah, great question. I think I can actually open up this box and I can see those questions come in a little bit better. Thank you for everybody sticking with me. I don't think we've lost a single attendee, so awesome. Let's see. So I am. Let's see, chat. Here we go. Okay, so for acne scars, that's an art. There's a lot of different ways to do it. We all know that acne scars that are more saucer-like do way better than acne scars that are ice pick type scars. So what I can tell you is when you have this patient with saucer type scars, they will do really, really well with aggressive mixed 2 by itself. And you may need to be doing about 5 passes on this area, but usually you're talking about an area no larger than a baseball on the cheek, and you're kind of feathering off of that. I would usually try to convince those patients just to go ahead and let me do their whole face. I charge the same. I'm so aggressive with acne scarring that I just really can't see doing it for anything different than what I usually do for a full face resurfacing. And so hopefully they've got other skin issues because that's going to be a bonus. I'm going to have to feather off of it anyway, and that's going to completely take care of, half to 2/3 of the face anyway. So I do 5 passes, and I'm going to do a combination of the deep 30-watt 10%. I might even, in an acne patient, do 2 passes at 30 watts at 10%. And then I'll do a pass or 2 of 20/20, and then a pass of 10% at 40 watts. I'm sorry, at 10% at 40% at 10 watts. And so you want to kind of layer that treatment. You want to be really aggressive with it. I've been surprised how many patients I did not think needed subcision, and I made a little nick in a little natural crease pre-auricularly, and I placed a probe or something under the skin and kind of lysed those scars, those adhesions, and that really, really helped my laser. So I know a lot of my colleagues have got some little cool instruments that they use to lyse scar adhesions. I've never gotten one of those. I keep trying to figure out where I can get one, and so I sort of use any number of different ways to do it, but usually make a little incision right in front of the ear and just just go underneath the skin and take down those scars. Similar to if I was doing a facelift. And I've got a question about a patient with a Fitzpatrick 2. I'm treating their whole face. I'm treating their neck. Can I go over settings again? Yeah. Start more conservative, maybe even than what I'm saying. But I'll tell you what I do in a typical Fitzpatrick 2. That's a dream patient because a lot of your ones don't have as much dyschromia, so you don't have as much improvement to give them. Once you start getting to 2s and 3s, if they've got some nice dyschromia, they're going to see a beautiful result. They've, of course, got a lot of photo aging going on. And so I'm just in general terms, I'm going to think about doing about 3 passes on that patient. You don't have to do it that way. But if I'm going to take the time to get them really well anesthetized so they can tolerate the treatment, I use a 30-watt 10% pass in general. I'm going to use a 20-20, and I'm going to use a 40% 10-watt pass. And just putting those together, it just seems to treat the skin at several different depths, and it just is a good workhorse way to go. Yeah, we've gotten really artistic with this. We sit down, and me and another staff member will talk through, how are we going to handle some of the little fine details. And we get really picky about little things in the face that we want to address, and we do things every once in a while. But at the end of the day, our workhorse way of going across the face is thinking in terms of an aggressive treatment being 3 passes, and maybe even some zones 4 passes. We'll add an extra 20-20 pass in if we need to. That's kind of the way we go about it. And then as far as the neck goes, again, I might could use 300. That would certainly be faster. But we're really pretty fast on the neck, and we do a pretty quick feathering. And I don't really like to treat the neck, although patients like it. And I can't think of anybody who's ever complained about their results. But I'm usually pretty tired when I get finished with the face. And I personally think rejuvenation of the neck is generally a surgical issue, either a lipo issue or it's a skin lifting issue. But certainly you can get some great rejuvenation of the neck with fractional CO2. And I'll go all the way down the neck with the equivalent of 1.5 passes, however you accomplish it. 1.5 passes of 20-20, again, 8 index, which is 2,500 on the pulse width. That goes out saying all these passes are 2,500 or 8 index. And then on the neck, I'll do 1.5 passes with the 20 watts, 20%, 180 spot size, 180 scanner. And I'll go down all the way down the neck, and I'll kind of feather onto the chest. But over the average, it's 1.5 passes. Let's see, that was a great question. What's my approach to this Fitzpatrick skin 2? Let me just kind of mention, I don't know if somebody asked this, but there's a lot of, no matter what you have in your practice, you may just do facial aesthetics. That might be your thing. You might be a surgical specialist. You might be non-surgical in your approach to the face. In my opinion, face is just something that no matter what you do, you can do better. You can add more techniques. More minimally invasive techniques is what patients want. But minimal surgery is a really, really great thing. And, they got terrible jowling. Here's what you say to them. I'm not a surgeon. Or, I am a surgeon. What my recommendation is that eventually you have at least a small incision facelift, if not a, small incision with an extension on your neck, because that's the only way that this part of you is going to really look exquisite. But, again, whether you're a surgeon or a non-surgeon, you will have so much credibility that comes to you if you tell that patient, I think you need a lift. But when you look at the risks of a lift when you look at the cost of the lift, when you look at the recovery of any type of surgical lifting, I don't know anybody in America that if they really objectively looked at it, wouldn't first say, let me spend the $6,000 or the 10,000 on resurfacing my face and volumizing my face. I can do the incisions later. That's always the order I do it. Even if I'm going to do a small incision facelift on a patient, that always comes later. It's not going to be any skin off of your back to have a loyal patient to you. Put your facelift off to later, or refer the patient to your surgical colleague and just tell them from the beginning, this is the referral that I make after we make your skin look younger and we do the volumization, because that's what the paradigm shift in facial aesthetics is. The paradigm shift is people look more natural when you fill them and when you take away their aged skin. If somebody has aged skin and they're devolumized and you try to only do surgery on them, they look horrible. So our surgical colleagues that are really, really good at doing surgical lifting, they're losing patients left and right if they're not given the priority to what it deserves, which is volumization and resurfacing, rejuvenation of the skin. So anyway, put things in the right order. Whether you have a surgical background or a non-surgical background, it's all the same. Surgery's later, whether it's done by you or whether it's done by a colleague. You're going to make a friend for life if you use the mix tube properly and you make sure it volumize the patient properly. Let's see if I've got another question here. That's the same question. I'm a little disappointed I don't have more questions. Nobody's flirting with me on this instant messaging thing or anything. So anyway, I'm going to ask the host if is that you, Rob? If there's anything else that anyone has messaged to you. Or
there's one question that came in. I think you've covered it mostly, but is there any special precautions, techniques for the darker skin types, 3s, 4s, 5s, 6s?
Again, I think that more than likely you could use some appropriate settings on any skin type and you could get some improvement. But you know what? I love patients. I want them to love me. My average skin type 5 or 6 patient that comes in that's asking for an improvement in their face, they probably need to have me do something else on them. There's no reason not to stick with your sweet spot. And when I have a 5 or a 6 patient, or even sometimes a 4 patient that comes in, the question should be, can I get away with this if I'm really, really slick and I do enough S-spots and stuff like that? The question is, whether you're sophisticated enough of a facial aesthetics provider that it doesn't always have to be about the laser. Sometimes it can be, they come in because you've got the whiz-bang laser, and the guys at lasering would love for you to send them some great before and after pictures, even though they've got a million of them. At the end of the day, all you really need to care about in that consultation room with the patient is, are you telling the truth to your patient, and are they going to be happy when you get finished? Fortunately, people wear their face on their face. Everybody's seeing it all the time. You can't hide it. You can't put it away. So patients don't want to cut back on quality. They want you to recommend to them what they need for their face to look natural and to look good, no matter what they need. So give them good advice. If that means tell them not to do the mixed two, show them your mixed two pictures, and they'll love you because they know you're doing the best work on the block or the city or your county or your area of the state or whatever, and use your mixed two pictures to credential you, but then give the patient what they really need, not what they want. And most of your patients that are skin type 5s and 6s, you're going to turn around the conversation. You're going to say, yeah, I could do laser on you. We're going to do some testing with you. Your particular scar issue, fill in the blank. Your particular sagging issue, bags under your eyes, whatever it is, have got some other solutions too. Now, I'd rather put the laser to the side right now.
Yeah, I think we'll take one last question. We're running a little long here, but you might see it at the bottom. Do you leave the serous crusting or remove it as the patients heal?
That's a great question. Yeah, we could talk for about 30 minutes about everything that I've gone through to figure out how to pre-treat patients before laser. What to use occlusion, something mechanical or a barrier. Do you use a petroleum-based product? I figured out a lot of that, but I'm still learning. And at the end of the day, what I can tell you is, no, I'm not going to remove anything off the patient's face. I'm going to let them bathe their face in the right product, and I'm going to let any of that eschar just sort of melt off. And really, at the end of the day, you can see from the series that I showed you on my esthetician, they really just from gentle washing of their face between reapplications of topical skin care, they don't really have a lot of problems with serosanguinous, eschar and things drying up and being cakey like that. There's not really an issue with that.
Well, Dr. Lawrence, I think that was a fantastic presentation. I do want to tell everybody that we have recorded this event, so if you want to view it again, you can go to the Lasering website. Please allow us a couple of days to put it up. If you have any more questions, Dr. Lawrence provided his email address, superducty@gmail.com, or you can call us at Lasering, and we can answer any of your questions there. Also want to remind everybody there's a special financing program, payments as low as $800 per month. You can contact us for more information there. We are opening up a poll at the right of the screen. If you have, we ask that you please take 2 minutes to fill out the poll. That helps us better create these events to fit your needs and Dr. Lawrence was discussing. I think that wraps it up. Dr. Lawrence, I'm going to thank you again for a great presentation, great information, and we'll end it at that. Thank you.
Appreciate it.